shown malignancy. Now the question is whether to do minimally invasive therapy or to go for surgery. This patient is a cirrhotic patient. So surgery was definitely out of question. So other question was chemoradiation. But we thought that even though it's cancer, and we went ahead with ESD. And start the video. Stop. Okay, it's okay. It's okay. Start the video, please. એ નીચે લઈ લે ને તો બહાર દેખાતો રહેશે તારું કર્સર નીચે લઈ લે જરૂર નથી બંધ કરવાની યા so basically this is an ESD for esophageal lesion. We are trying to do it with a pocket method. So initially the distal incision is made, and then from the proximal end, after marking, we are trying to create a submucosal tunnel. This is a dual J knife. You can start with TTJ knife, but I am more worried about TTJ knife in this scenario because it can cause muscle injury. Once you elevate the lesion, we are going underneath the lesion, and as you can see, it's just like a poem that we have created. And then once the pocket is created, we are cutting it by the side. So this is the right side we are cutting. This is the muscle layer. And you can see once the right side and the lower part is cut, we would take the left side. So now we are cutting the left side. This is the last part that I am cutting with a coag grasper actually. So it's absolutely free. You can see the muscle. Now the biopsy had shown malignancy, mainly mucosal, but one part was more than 200 in submucosa. So now patient actually never wanted to go for chemoradiation, and that's why I did ESD. I had done in EUS, and EUS had, as I told you, had not shown any muscle involvement. So now I asked him to go for chemoradiation, because even though it's a little tiny, entire like 99% or 98%, it's free. There is no submucosal involvement. But even one segment, one tiny part is going beyond 200. So here, NBI was definitely showing malignancy with a possible submucosal invasion. So this was a borderline case. But if it was 100% case, I would have asked the patient, I'm not going to touch it. Next slide, please. Next slide. So Paris classification, as sir said, is absolutely mandatory. If you have 1P, don't worry, because it's a peduncular polyp, just take it out. If it is 2AB, most of the times you are fine. Most of the times it could be early cancer. If you have 3, definitely it is an invasive cancer. Nothing else is required. You don't touch that patient. Type 1S, 2C, you have to be more careful. It could be either way. So it's not just NBI, it is also Paris classification, which will tell you whether to go for minimally invasive endotherapy or not. Next slide, please. Can you touch the first video? Yeah. So this is NBI. આટલું જ છે ના ચાલુ છે. Yeah. Stop. You want to comment, sir? Or you want more? Yeah.
I would love more their images. But yes, what we are seeing very clearly.
Can you read on it?
Okay, what do we look in the stomach? Well, features are, of course, here on white light itself, you're seeing a kind of a polypoidal lesion, 1S lesion, and that is suspicious. Now the question is it a benign kind of lesion? Because there are several kinds of polyps that we see in the stomach. One, is it subepithelial lesion? Is it an epithelial lesion? And for that, you'll see what is called the line of demarcation. Is this the same lesion, different lesion? Right?
That is the same lesion. This is white light. That was NBI.
Okay. If you find out.
Stop.
I wish I could see a little more of this. But here you can see. Yeah, I think there is a line of demarcation. So which tells me it is epithelial. And once you look at this.
Run.
I'm sorry.
Yeah.
I can't.
Run. Stop. Yeah.
Now here you have to look at the surface pattern and the vessels. I'm sorry, I can't get a great view of this thing. I don't know whether there is some amount of white opaque substance here, suggesting whatever it is to be fairly well differentiated. So if it may be an adenoma which is well differentiated, or maybe
biopsy was well differentiated adenosine.
Well, yeah, that's what it is. It's a well differentiated tumor is all that I can say.
Yeah. So then we did EUS, and then it was not again involving muscularis propria. So can you complete it or yeah. Also there is a lot of light. I asked because for them video is more important. Okay, run this please. So so after marking this is CSD. You can fast forward. बच्चे करते हैं कारण के तो लगभग so this is the last part we are taking it out. बस बराबर ना करते हो. And then we are coagulating the vessel. Biopsy had shown well differentiated adenosine without deep submucosal invasion. Next slide, please. Okay. Then colonic lesion, colorectal lesions. Again, we have to find out which are the lesions which have higher chances of submucosal invasion, and the lesions which are non-granular, they have higher chance compared to granular lesion, 10 to 15%, but at 2%. Lesions, if they have nodules or ulcers or depressed or Kudo pattern 5, they have higher chance of submucosal invasion. If the lesions are larger, they have higher chance, and this is most important. If you have a lesion in rectosigmoid compared to other parts of colon, they have a higher chance of malignancy. So if you have a lesion in rectum and sigmoid, ESD is preferred, especially if it is non-granular, if it has a nodule or a depressed component. But otherwise, rest of the colon, you are fine. Whether you do EMR or ESD, and I don't do ESD in rest of the part of the colon because there are extremely high chance of perforation, as you can see it in duodenum. So for us, the best part is rectum and sigmoid. The best is rectum. Rectum, when you are doing ESD, there is a good point that even if perforation occurs, if it is in the lower part, you are fine. You don't do anything. Nothing happens because it is extraperitoneal. Even if it is perforation which is intraperitoneal, you can close it very conveniently, very easily. Sigmoid is a problem. Sigmoid, and I'll show you one perforation sigmoid. Uh, Rest of the colon, I would not prefer or I would not advise to do an ESD. Rest of the colon, it is the piecemeal EMR, which is sufficient in almost 99.99% of the cases. Uh, So those patients, those lesions which are non-granular large lesions with nodule depression or Kudo pattern 5 have higher chance of colonic or submucosal invasion. Colon is good because colonic mucosa does not have any lymphatic drainage. So if your lesion is purely in the mucosa or even early submucosa, chances of lymph node metastasis are very minimal. As you can see, all mucosal layer, 0% lymph node metastasis. SM1, 0% metastasis. So you are good till SM2. If you are SM1, you are good because there is no chance of lymph node metastasis. Again, NBI can tell you about the deep invasion. It cannot tell you about the SM1, SM2, and SM3. SM1, SM2, SM3, your pathologist is going to tell you. So if your pathologist tells you that it is less than 1000 micron, you are good. So less than 1000 micron in submucosa, meaning you are good. You don't have to do anything. More than 1000 micron, there are studies that if other features are not negative, means if the tumor is well differentiated, if the tumor does not, if your ESD has good lateral margin, and here good lateral margin for R0 resection is only 2 millimeter. You don't have to, if so, you have a margin of 2 or more than 2 millimeter, more than 2 millimeter, 1 or 2 is not good, more than 2 millimeter, you are well covered. So all other features are good, and your vertical invasion is say 2000 micron, still you don't have to do anything. So colon, that way is very forgiving. So start the video. So this is a lateral spreading tumor, but NBI, when we started, it's not showing any negative finding. So here you can do EMR or ESD. There is no added advantage of ESD in this kind of lesion because it is granular. NBI is good. There is no submucosal invasion. And again, it's a higher colonic lesion. So it was in descending colon. So EMR is the preferred therapy. Can you just run the video? No, no. Yeah, run the video, please. Just, you don't have to do anything. Just on trackpad, just do tuck and it will start. And when you tap your finger again, it will stop. So you know that in piecemeal EMR, you start from the one margin, then you take the cut margin as your guide, so that you don't leave any island, because taking out those island would take more time and more effort. Next slide, please. हमारे करवाने. Okay. Stop. So this, can you take your, yeah. So this NBI, you can run. No. Just tap the finger. Tap. It will start. Tap again and it will stop. Tap again. Yeah. stop. So we did an NBI, and when you are doing NBI, you can see that I was the way I was doing it. You have to go near, turn the scope, so the lesion comes into, and always do it with the cap. And you have to see not just the front, you have to see the back. So you have to see all around. So that is the method to do an NBI. Can you run it again, Pratik? And now you can see. See, how am I doing it? So then we planned, this is a sigmoid colon lesion, and we were pretty sure that this is not having any submucosal invasion. So again, mucosal incision is made. You in ESD you have to find the right plane. Many a times because you are worried, you go into a submucosal superficial plane. That is not the good thing to have. And I thought there was some deep muscle injury, so I changed my plane. But you can see even while changing the plane, I had deep muscle injury. So just look this. So this is a deep muscle injury. So it is just like a perforation. Don't worry, just keep on doing your ESD. So we completed the ESD, and you don't have to close the entire defect. You can just close the deep muscle injury. So that's the deep muscle injury. And just two clips, and it should be good. Next slide, please. Yeah. So this is a lesion which is in the lower rectum at the anal verge. It's a huge lesion, but